Thanks. But of course, please be interactive and use the chat. I might miss some questions, so if Prof can let me know and interrupt, please, yeah, ask questions as we go along. So just note there'll be a couple of quiz questions as we go along, and this is the code for Menti that I think you probably all used before.
Yeah, we have.
Yeah, cool, excellent. So we thought it'd probably be quite an opportune time to talk about COVID, which we've probably not done for a while. So obviously we all should have treated people with this condition now, and we are potentially at the start of another wave. Wave number 3, I think, if you're counting. So hopefully we're in a better position than we were at previous waves, but obviously we still don't know entirely what's going to be around the corner. So I think the government would like us to believe that it might be a sort of nice, benign, friendly wave like this. But some of us think it might be a bit like this. But hopefully we're somewhere in between. Obviously we don't know at the moment, but we can hopefully make some sort of predictions from the data. There's lots of useful stuff on the government data website. This is just UK cases, which are going up very rapidly. And actually now we are at a similar level to January across the country in terms of diagnoses of new COVID every day. But obviously this is tempered by the fact that lots of people have been vaccinated. This is the numbers nationally for first dose. So we're over 40 million people have had their first doses of the vaccine across the UK. And over 30 million have had both doses, which is a pretty phenomenal achievement, really. But despite that, numbers are going up. This is obviously most relevant to us. Numbers of cases being admitted to hospital. We're all feeling it, I think, if you've done any acute medicine recently. And this is very similar picture for people actually ending up in ITU. However, this should hopefully provide a little bit of reassurance, perhaps, the fact that although we're seeing huge rise in cases and also a rise in hospitalizations and ITU admissions, this is yet not translating to huge increases in numbers of deaths, thankfully, which presumably is due to the vaccine and perhaps the fact that a lot of people we're seeing now are younger, so maybe have a less baseline risk of death from this condition.
So Richard, so on this slide, you've got daily 63. Is that yesterday, 63 deaths?
Yeah, this was yesterday evening. The data apparently was up to date 4 p.m. yesterday. 63 daily deaths.
Because we all remember there was a day when we had 0, so that's a big increase.
Yeah, true. Yeah. But nevertheless, there's a huge discrepancy between daily cases and deaths at the moment. Long let that continue. So this talk is essentially going to be a overview of how to look after patients with COVID in hospital. A lot of you will know most of this stuff anyway, but a few things have changed since the last wave. And all the slides here are based on a presentation that Nicola Reed, one of the respiratory registrars, and I did about 6 months ago. And if it's useful, we can circulate the slides afterwards. So there's quite a lot of stuff in here, as I said. But it's kind of, I think, the main points from all the many trust guidelines hopefully covered in this. It's a lot of stuff I'm going to skim through quite quickly, but please try and slow me down or stop me if things aren't clear or if there's a... So hopefully by now we know what COVID looks like when a patient with an acute respiratory syndrome with a fever, low lymphocyte count usually. But the main differential diagnosis, of course, is pneumonia. But the chest x-rays usually are very different. But this is a classical lobar pneumonia, very different from the diffuse bilateral change that we see in COVID-19. One of the first things to consider, obviously, is does the patient actually need to come into hospital? There are, like it says here, no hard and fast rules, but the clear thing is hypoxia. And the criteria that we suggest would be less than 94% on air, or if you do a sit to stand test, which is described here, whether they desaturate significantly. Clearly, there might be other issues, social problems, inability to self-isolate, and so forth. And here, this slide is just this is kind of just an overview of what you do when someone comes into a hospital. So this is something that needs to be considered for every single patient who's admitted to the hospital. Setting a ceiling of treatment. So if this patient was to deteriorate, would it be appropriate for them to go to ITU? Not a very easy thing to do in some cases. Often it might involve discussing with several different people, but it is something that needs to be considered at the stage of the post-take ward round. And in terms of the diagnosis, I think I would say that have to have a low threshold for doing CT scans in these patients, because yeah, again, it's difficult to give hard and fast rules, but if patients particularly are relatively quickly increasing their oxygen requirement, say from 2 litres to 4 litres, there may actually only be a limited time window to safely get them into a CT scanner. So we are looking for pulmonary emboli and other potential diagnoses. But it also helps further on down the line if this patient is going to deteriorate, and in terms of which I'll come on to later, questions about whether we give enhanced steroid treatment. So it's useful to do CT scans in many of these patients. Oxygen, I'll talk about, document it clearly. And I think one of the key things that we want to get across as a respiratory department is please let us know early if you're worried about patients. This is kind of, particularly if someone's on 40% oxygen or more, or like I said, it's quite rapidly deteriorating, even if they're not on that much oxygen yet. Please let us know. We'd rather be called early than not at all, and to suddenly find this patient by accident when they're very sick. So I'll come on to this more later. So respiratory registrars are available at Charing Cross 8248 between 9 and 5. And from Monday, we have a return of the out-of-hours respiratory consultant available via switchboard, which would be contactable through the acute medicine consultant. So we can maybe discuss that pathway a bit later. But so just the key message there, please let people in respiratory medicine know if you're worried about patients. If they're on 35% even, or quickly deteriorating, but definitely 40% and above, we'd like to know about these patients. In terms of doing ABGs, not necessary in everyone, but can be useful in terms of trying to work out how sick people are if they're on 40% or more of oxygen. And just another point, just look further on down the line, which I'll come to. Once the patient's in hospital, encourage them to mobilise and there's a good physio guidance that I'll come on to. Early, kind of repeating what I said already, early involvement of respiratory team and ITU. So there's some criteria later that I'll talk about for, say, 60% or above oxygen. It might be a good time to speak to ITU as well as respiratory. And to say the things in red, by the way, on this slide are things that have changed since we last did this presentation 6 months ago. So key point is that standard of care for all patients admitted to hospital with COVID who are on oxygen is now to give tocilizumab as well as dexamethasone. I'll talk a bit more about this later. And then something that shouldn't be forgotten: if patients obviously don't respond to treatment and are clearly deteriorating, involve palliative care early. So that slide is basically just a very brief, quick overview of what I'm going to be talking about in more detail. Again, this is just coming back to a point about assessing patients for how sick they are, and please don't be fooled by people who look and feel okay. I think sort of many of us have looked after lots of patients now with COVID, many of whom have been extremely sick, and particularly in wave 1 and 2, we kind of got quite used to looking after patients on huge amounts of oxygen on just normal wards. And I think some of us maybe have kind of forgotten that that's not normal. And clearly pre-pandemic, we would never dream of looking after patients with 40% or 60% of oxygen just in a general medical ward. So once these patients are on oxygen, they can, feel okay and they can look okay, but obviously they're not, because they're on masses of oxygen. And so I think it is quite easy to be fooled and to underestimate how sick these patients are and how rapidly they can deteriorate. The clearly obvious things to look at are oxygen saturations, how much oxygen they're needing, respiratory rate, and then NEWS score. Chest X-ray findings can be a marker of severity in terms of how much shadowing there is, and blood tests can be useful as well in terms of a very low lymphocyte count, very high CRP, and very high ferritin, all markers of significant disease. And if the patient does have an ABG, there is this thing called the PF ratio, or so it's the PaO2 in kilopascals divided by the fraction of inspired oxygen as a decimal. So this severity scale, this is how you essentially assess the severity of ARDS. So clearly someone might have a normal PaO2, say 12, but actually if they're on 80% of oxygen, then they're extremely sick. And just getting this number, the PF ratio, if they were breathing in air, the PF ratio would be 57. If they're breathing 80% oxygen, the PF ratio is 15. So there's this ratio is kind of just a way of allowing for the amount of oxygen someone's on when you look at their PaO2, and anything less than 20, that ratio, the orange there, is pretty bad, and anything in red is very bad. And definitely in the orange, ITU should know about the patients, and the red, the patient should be on ITU now, I would say. And obviously trends are very important as well. There are various ways of trying to predict who's going to deteriorate and to give a marker of in-patient hospital mortality. There's something called the ISORIC score, which people may have heard of. This study was published at the end of last year, which essentially takes in all these different factors: age, sex, comorbidities, respiratory rate, peripheral SAT, GCS, urea, CRP. And obviously, the more points you have, the higher inpatient risk of death. I think it's actually death within 28 days, actually. But these actual figures, though, may be slightly out of date because so the mortality here goes up to over 80% for patients who've got the highest score of over 20. So probably, though, this doesn't take into account the effect of tocilizumab and dexamethasone and other things. But so it's not so much the actual percentages that are important, but just the kind of general message that these are all things together that can impact on someone's risk of mortality. So it's obviously the baseline physiology when you assess the patient, comorbidities, age, sex, and a few blood markers. I feel like I'm repeating myself here, but I think this is just a very important message that I think Dr. Brown will probably echo this, particularly who's been on the ward the last few weeks and has been dealing with some of these patients who've been in. Please let us know early about patients who are on oxygen and who are getting worse. I've just suggested some criteria for when you call respiratory. As I've said before, high respiratory rate, high oxygen usage, and so forth. So in terms of actual whether you call ITU as well, if someone's very sick, 60%, ITU definitely needs to know about the patient. But during the second wave, respiratory were kind of acting as a liaison between both ITU and ARU. So within hours, 9 to 5, if you're going to call ITU, please call us as well. And if you're just in doubt, just call both, essentially. Okay, so now we're on to specific drug treatment and what you put on the drug chart. Obviously, oxygen with target saturation should be prescribed. So VTE prophylaxis, this is a sort of whole minefield, which we could talk probably for hours on this. I'm not an expert on all the data that have come out and all the various debates and all the trials, but this information here, by the way, is all taken from the hospital guideline management of patients with confirmed COVID-19. And I think we're on version 14 now, I think. So essentially, the message is for VTE prophylaxis. If a patient's admitted to hospital and is on oxygen and is just on a general ward, then consider giving a full treatment dose of VTE prophylaxis. However, once a patient needs level 2 or level 3 support, then perhaps counterintuitively, the recommendation is to reduce the dose of VTE prophylaxis. This is the outcome of some large trials that have looked at this in terms of the benefits of VTE prophylaxis in patients with COVID. It seems to be that the benefit of higher doses seems to be absent in sicker patients. We can perhaps debate why this might be more later, but I think probably the reason is that the bleeding risk increases as patients are sicker. So any benefit of VTE prophylaxis is negated. I mean, that's my understanding of this anyway. So the other thing to mention is at one point during the various waves, there was a vogue for discharging patients with extended VTE prophylaxis. That is not now routine practice or routine recommended. However, if there are other strong risk factors for VTE, such as recent immobility or extreme obesity, etc., that's something that can be considered within this guideline at the clinician's discretion. Everyone should know, obviously, that we give dexamethasone now to all patients who are admitted with, if on oxygen, with COVID, thanks to the recovery trial data which came out probably almost a year ago now, actually. Remdesivir is recommended for all patients who are needing oxygen with COVID-19. The data are definitely not as strong or as compelling as for steroids. Mainly the benefit seems to be in terms of time to resolution of symptoms, but it's in the guideline and it's recommended. Avoid though in pregnancy, liver and renal failure. This bit should be in red. This is new, tocilizumab. This is now standard of care for all patients admitted with COVID-19 who are on oxygen. It's given as well as these other treatments. So there's no need now to go through a treatment approval group, which used to be the case. So this is now standard of care for all patients who have COVID-19 who've been in hospital less than 48 hours, who are hypoxic, and sorry, I think there's a bit missing there. So CRP, there's a CRP criterion for this. So CRP needs to be 75 or above. So just write it on the drug chart, make sure the pharmacist is aware, and these patients all should be started on this drug. So some key things to know about tocilizumab. Contraindications are other coexisting infections and liver disease. And the other key thing to know about this drug is that once you've given this medication, measuring the CRP becomes completely pointless, because this drug blunts the production of CRP. So you can't then use CRP for monitoring from then onwards. And that effect probably goes on for maybe up to 3 months or even more. This is, as I say, this is a bit complicated, and because there is a caveat to what I just said, in that if a patient has gone directly to ARU or to ITU, and rather than tocilizumab, the preference is for this other immunomodulator drug called savolumab. I hope that's clear. But like I say, I can circulate these slides later, but all the details are in this full guideline, which is available on the internet.
Before we move to this slide, do you want to just say a few words about target oxygen sats?
Yes, I'll actually come on to this in a minute.
Okay, thank you.
Yeah, so I've got a different slide about that. And then just the final thing to mention about medications routinely are antibiotics. So carefully consider whether these are needed. Clearly, antibacterial drugs are not effective against COVID-19. But on the other hand, it can be very difficult to confidently exclude a coexisting bacterial infection, particularly if someone's very sick and has got fever and is deteriorating. So I think whilst most of us would hopefully avoid antibiotics in the first phases when patients are just on a small amount of oxygen, I think it reasonable. Well, this is just from speaking personally. I would say perfectly reasonable to consider antibiotics once patients are getting more unwell. I think someone in AMU wants to ask a question.
Hi Richard, it's George here. Just to say, what an excellent talk that you're giving. Could I just clarify just about the TOCI? In addition to what Dr. Brown has written about the need to cancel that it's unlicensed, I think the less than 48 hours is for a medical consultant to approve it without the panel. And after 48 hours, you can still prescribe it, especially if you're waiting for that CRP to go above the threshold of 75, but then it needs to go to the panel. And the panel, fine.
Yeah, thanks very much, George, for clarifying that. Yeah. It's quite difficult, isn't it, just to give clear messages about all this, because things change and there are caveats. But like I say, it's everything is in this main guideline. But thanks, George. That's a good point.
And there's a question about procalcitonin. You mentioned CRP.
Yeah.
The question is, does that play a role? Procalcitonin.
Very good question. So is the question whether tocilizumab affects procalcitonin? I think if that's the question, then I think the answer is we don't know. I think no one's actually sure on this actually. But if someone else knows anything different, please let me know. But procalcitonin is very useful, as we all know, for trying to identify bacterial infections versus viral infections.
So I think the question is, would you use a high level of procalcitonin to decide on?
Oh, I see. Yeah. So certainly, if there's a very high procalcitonin, that would make you strongly suspect a persistent bacterial infection, which may make you very wary about giving tocilizumab. So the patient obviously needs to be very carefully assessed. I should add, I think I mentioned this later. Any tricky cases like that, please flag up to us in respiratory, and we often don't know the answers. So we have a regular MDT, which is cross sites for discussing tricky COVID patients. So at the moment it's running twice a week. I think at one point it was every day, actually, Monday to Friday, during the last wave. Okay, so that's medications. Do we want to do a quick quiz? I don't know. I might mess up the whole presentation after this, but shall I? Let's try and do this, because otherwise it's just me talking.
Yeah, go on. Go Alt tab into the other thing.
So we're halfway through. Otherwise, it's just me droning on for an hour. Alt tab.
Yeah, that'll get you to your others. It'll be a Zoom screen, and then you can choose the tab. There you go. We can see it.
There you go.
They're answering already.
Can you see it there?
Yeah, I can see it in the recovery study, and there's 3 people who voted.
How have they done that already? Oh wow, amazing. Present.
Yeah.
Can people see that?
Yeah, we can.
Okay, so people are going to be influenced by what other people are voting, aren't they?
If you want to hide it, the next one, if you just take your mouse to the left hand, near the bottom left hand corner, you'll see a little toolbar will appear. Go left.
Oh yeah, yeah.
And you can hide it then.
Okay.
Yeah.
I'll hide it for 30 seconds or something, and then you can have a think. So in the recovery study, what was the relative reduction in mortality with dexamethasone compared to standard of care in all hospitalized patients?
Okay, and just to tell everyone, you need to go to menti.com and put that code in 7724-4470 on your phone, then vote. You got 14 votes actually. That's quite good.
That's good. Yeah. So I've just got the free version of Menti here, which just lets you do 2 questions.
Oh, I see. Okay.
So it's going to be quite a short quiz.
That's all right. Anyway, you can, why don't you reveal and we'll have a look and see.
Let's have a look.
And this is the answer.
It's interesting. They're still going up and down a bit, I think. So the answer actually is 17%.
Okay, that's a bit disappointing.
Yeah. So more people getting the right answer now.
Yeah.
So relative reduction in mortality with dexamethasone compared to standard of care in all hospitalized patients. So this was everyone, admitted to hospital last year. The 28%. Hold on, I've got some notes somewhere. I can't remember. I think Graham knows the study quite well actually. So amongst patients who are admitted to ITU, the benefit was higher in the dexamethasone study. That was the 28% figure, I think. But amongst everyone admitted to hospital, it was 17%. I'll try and go to the next question. How do I do that?
If you go to the toolbar, that's it there.
There we go. All right. Okay. Good. Yeah.
And then hide it as well, because as we vote, it'll.
Oh yeah. So I'll hide that. So this is maybe a little bit of a geeky question, but it's interesting. How does tocilizumab work, essentially? So I've told you here, the study which we're basing the use of tocilizumab on, again, is for the recovery study, which published in the New England Journal of Medicine about 6 months ago now, I think, which has shown a 15% reduction in mortality with tocilizumab in hospitalized patients who are hypoxic. And I think that might be in Lancet, actually, sorry, this paper. But so if people have a vote there, so what's the pathway?
Yeah, you're more than last time. We've got 17, so everyone's who had voted last time has voted. Ooh.
Well, everyone knows this one. Anti-IL-6. Very good, excellent, well done.
Thank you.
Someone's been paying attention to something along the way. So now I'll go back to the presentation. The Alt tab.
Yeah, that's it.
Is that? Can you see? Can you see a whole screen? Or,
We can.
Yeah. Okay, good. Right. So oxygen. You can read that. So when patients are admitted to hospital initially, we like to aim for oxygen within the normal range, oxygen saturation in the normal range, 94 to 98, or 88 if COPD or chronic hypercapnic lung disease. But then once the patient's stable, which is quite difficult to define actually, the hospital guideline in line with WHO guidance goes for 90% and above being perfectly acceptable. Which is all about part of trying to conserve oxygen, which I'll mention slightly in a minute. And so that's one thing to say about oxygen. And the second thing to say is that when you're talking to us in respiratory or talking to ITU, it's helpful if you're talking about how much oxygen people are using, rather than just giving a flow rate, to give the delivery device as well. Because particularly if you're saying this patient's on 15 litres of oxygen, that might mean they're on 60% FiO2, or it might be 85% FiO2, depending on whether it's a Venturi device or a non-rebreathe bag. And depending on what their SATs and their PaO2 is, obviously that's a quite different severity of illness if patients are on 60% or on 85% with the same SATs. So when you're communicating oxygen, please talk about the flow rate as well as the delivery device. Don't just say the patient's on 15 litres. And just going back to the Venturi nozzles, it's very useful just to familiarise yourself with the colours. So you can, when you're doing a ward round, you're seeing patients from the end of the bed, how much oxygen are they on? Have they got a yellow nozzle or a red nozzle or a green nozzle? So a red nozzle means the patient should be known to us in respiratory because they're on 40%, or even a yellow nozzle, actually, we'd be happy to be told about. But if someone's on a green nozzle, they definitely need to be referred to respiratory and probably ITU as well. So just remember the colours: yellow, red, green, 35%, 40%, 60%. There are other ones as well, but these are the most commonly used in this hospital. And then just a message here about conserving oxygen. This was particularly an issue during the second wave, where the hospital was flooded with cases of COVID pneumonia. Hopefully it shouldn't be that bad, but who knows? But just a message, obviously give only enough oxygen, sort of don't give too much. And when you're looking at the ball on the gauge, the ball should be on the number rather than above the number, because that can be lots of extra wasted oxygen. The simple things like making sure that oxygen tubes and masks, if they're not in use, they're being turned off. That's just different sorts of masks, which we've talked about already. And just a quick summary in terms of all the stuff that you're supposed to prescribe and do for when someone comes in. This doesn't actually include tocilizumab, but there's a COVID red coat acronym thing. And if you actually, on Cerner, if you type this if you dot .cov, that comes up, and then it'll give you a list of all the stuff that you should be thinking about when you're on a ward round. And tocilizumab is extra because that's not included in there. So I think we've talked about all those things pretty much so far, or most of them. And I'm going to so everything I've talked about so far is standard for all patients with COVID-19 that should be considered when they come into hospital, whatever severity, assuming they're on oxygen. These are just some other things that you need to know about. This is a picture of some animals. What am I thinking about here? Who wants to put their hand up and say, why have I shown lots of pictures of cute animals and some people from 2 different medical specialties or surgical specialty, perhaps, but this is just I'm talking here about proning.
Yeah, someone got that in the chat.
Great.
Except they called it self-proning.
Yeah, this is just to indicate that most mammals spend most of their time with their tummies down, even when they're asleep. We don't, of course, because we've got 2 legs. But I've got no evidence for this, but it just suggests that for most of evolution, mammalian lungs probably evolved to work best when the tummy's down, or at least when the tummy's not up anyway. And there are physiological reasons to theorize that the lung should work better when the tummy's down rather than the tummy up. Just in terms of the shape of the chest, and if you're lying on your front rather than your back, it gets the abdominal contents sort of out of the way. So if you're lying on your back, especially if you've got a big tummy, it's going to be that's going to be pressing on the lungs. There's more lung tissue at the back rather than at the front. So if you're lying on your front, most of the lung tissue is going to be pulled open rather than squashed. Also, blood flow within the lung is better along the back part rather than the front part. So if you're lying on your back, blood flow is going to be impeded more. And we know that from ITU, there's lots of evidence in intubated patients for proning being beneficial in improving ventilation. So hence the idea that awake proning might work. And we've all seen it done. And the general recommendation, as far as I can see, is to consider this and to try it. I mean, it's definitely not to be done instead of escalating to ARU or to ITU, but it is something that can at least potentially help stabilize a patient. And I mean, the evidence that's being done, I think, is generally of low quality, but I think there's kind of definitely a lot of anecdotal evidence that it helps, and it seems not to be harmful. So it's something that certainly should be considered and tried, but like I say, definitely shouldn't be something that would. I mean, if you're getting a message that the patient doesn't need to go to ITU yet because they haven't tried proning, then no, that's not the case. It's something that could be considered and tried, but as an adjunct to doing other things. Now, acute respiratory unit, we have, as you probably all know, our main ARU is on 4 South at Charing Cross Hospital now. We have up to 6 beds on 4 South. As of yesterday, 4 of them were red, as in for COVID positive patients, and 2 of them are for COVID negative patients. and there may or may not be extra ARU capacity brought in on Marjorie Warren ward as well. As it in wave 2, we had 2 ARUs. There is now provision being made at this week over the weekend to use to have a second ARU if needed, in terms of the infrastructures there, in terms of ventilation. Obviously, any patient being considered for ARU should be discussed with the respiratory consultant, now including out of hours. And the sorts of patients we want to hear about, like I said before, patients with, keep on saying this, patients on 40% or more of oxygen, or generally anyone else that you're worried about who's looks sick. And there's been lots of debates during the pandemic about the roles of different ways of giving oxygen to patients with COVID-19. And there's no general consensus yet, I don't think. And different hospitals do things in slightly different ways. Some hospitals have opted not to use CPAP or high flow at all, hardly, and have had a very low thresholds for intubating people. Some people have had only intubated people extremely late in the course of the illness. I think we've at Imperial and Charing Cross in particular, I think because we didn't have this available at the first wave, but I think we're somewhere in between. There's lots of other stuff that we do in ARU though that's probably beneficial to the patient, as well as giving Optiflow or CPAP, because these patients obviously all on monitors. They're being looked after by nurses who are very used to looking after patients with respiratory failure. These patients are all getting seen by a respiratory consultant at least once a day. So I think there's no debate now that the acute respiratory units have been helpful in this pandemic, at least locally so far. And I think we have probably saved some ITU beds. And I think we have helped offloading patients from ITU once they've started to recover. So I'm kind of running out of time, but aren't I? So I'm not going to say too much about. So that's CPAP, and that's high flow nasal oxygen. So different things that we do on ARU in terms of delivering oxygen to the patient. So both of these are interventions for type 1 respiratory failure. There was a research study that we were recruiting to called Recovery RS, which got a confusing name, nothing to do with the recovery drug trial. This is Recovery RS, that was comparing different approaches of giving oxygen in patients with COVID-19, which hopefully should be reporting in the next month or so, which might give us some insights into which is the best way to give oxygen. I think I'm going to probably start wrapping up now, because I've only got a few minutes left. This is just slides just to please remember, for every patient with COVID-19, consider research studies. There's still a lot that we do not understand about this disease. We've clearly learned loads in the last 18 months, but there's still an unmet need for treatment to help reduce mortality. And these are the two main studies that we're recruiting to at the moment, as far as I'm aware. MATIS, which is a local Imperial study led by Nicola Cooper, and obviously the large and multi-centre national recovery trial as well. And the main things that these studies currently are looking at is various modulators of the inflammatory cascade within the condition. And there's an excellent team of research nurses who most of you have probably seen, and they're very proactive in terms of finding patients, and will probably be approaching us on the wards to ask about recruiting patients. But otherwise, you could bleep the respiratory regs who should know about these studies. Another quick point I wanted to make is that the other role I think that we have in respiratory is not only at the front end when patients are very sick and you want to know where they should go and how best to give them oxygen, or whether they should go to ITU, etc. It's also in the patients who are slow to improve. Some might be sick, some might not be sick. I think we've all seen there's a group of patients who just get stuck on 1 or 2 liters of oxygen for kind of a long time. In some of these patients, I'm not going to go into this in detail, but there is a role for enhanced steroid treatment. And it particularly works for this so-called organizing pneumonia phenotype. There's a specific pattern of lung inflammation that seems to develop in a subset of these patients, which you can diagnose by CT scanning usually. And we discussed these cases in our MDT cross-site. But there's some patients who have completed the standard 10-day course of dexamethasone who may still benefit from either a longer course or even a higher dose of steroids. So essentially any patients who are not getting better is the main message. Please let us know as well. There's some links at the end of this talk about good resources. So hopefully these should be available on the wards, but it's very important that patients keep moving when they're in hospital, and breathing exercises. And there's some information in this excellent leaflet about self-proning for patients as well. And finally, just coming on to hospital discharge, essentially, main thing is patients shouldn't be needing oxygen anymore. And there's a sit to stand test can be helpful in terms of looking at whether patients are still desaturating, although because they clinical judgment is key, and please involve us again if you're unsure. And this isn't actually in place at the moment, but it was in wave 2. I think it's very helpful in terms of helping to discharge patients, particularly those who are maybe a little bit borderline, or particularly if there's social issues or significant anxiety. So the community respiratory teams at this hospital and at St Mary's were involved in as probably most of you know, a virtual ward in terms of phoning patients regularly and giving them an app, if they could use it, to actually upload their oxygen saturations, because they went home with a pulse oximeter. And there's just some so this is actually not actually operating at the moment, but I think it may be again. So let's watch this space. And this is just some information in the slides which we'll send around about sorts of things you should be putting in the discharge summary in terms of making sure they've got advice about if they've had COVID, obviously need to isolate for 10 days. And another thing we should say on this, actually haven't said, please make sure talk to patients about vaccine. A lot of patients unfortunately have not been vaccinated, which is the reason why they've ended up in hospital. And the advice, as far as I'm aware, is that you need to wait 28 days after you've had COVID before you can have your first dose or subsequent dose of vaccine. And then in terms of follow-up, anyone who's been, I think these are still the criteria, as far as I'm aware, they haven't changed, but in this hospital follow-up available for everyone who's been on 40% or more of oxygen. So email Thessalyn White, who's one of the respiratory nurses at St Mary's, and she will help organise that. And then just some sources of information which you can give to patients about fatigue, breathlessness, what to expect, how quick to recover. This NHS Your COVID Recovery website is very helpful, by the way, if you've not seen it. And then in terms of just, this is just where all the information in this talk has come from. It's basically from these large number of trust guidelines. And in terms of clinical information, up to date is very useful. And the BMJ has also been very helpful during the pandemic in terms of giving lots of free articles on the pandemic and the condition. So I think that's me done. I've not left much time for questions, I'm afraid, but I'm happy to answer any.
Thank you very much, Richard. Actually, that was really clear. We're likely to review the cut-off for hospital follow-up patients. This is from CM280. Who's that?
Sorry, it's Meg Coleman.
Hi.
Sorry, I've been hiding in the background. I find that very helpful. So thank you. I was just going to say that we currently, as Richard said, have been following up in a hospital clinic anyone who had required 40% or more oxygen during their COVID admission. Our experience, we're just looking at the data now, but our experience is the majority of those actually get completely better, and therefore probably don't necessarily need sorry, I can't even turn my camera on. Probably don't really need hospital follow-up. We haven't yet worked out how to reset that to catch the proportion of people who do need to be seen and the ones who don't. So we're going to leave that as it is for now, but just beware that we're likely to change that cut-off a little to reduce the amount of hospital follow-up appointments we need. I think we've seen 600 since wave 2. And it's just somewhat unmanageable when 60% of those have returned to normal by about 10 weeks. So it's good news, most people get better. It's just, there is a proportion we do need to see, and I can't quite tell you who that is yet.
Richard, can you see the questions? There's a question about a specific about asking whether it's CT or a CTPA, and there's an example of a 110 kilogram young person who's on day 5 of illness getting worse, winding up the FiO2.
That patient would benefit from a CT, I think. 55% of oxygen. So if outreach nurses have been very helpful actually in terms of helping to accompany patients to CT scan if you're worried. But a patient like that is a perfect one that you should discuss with us. Definitely, that patient should.
Yeah. Thanks. It's one of the paediatric IDE consultants in St Mary's. It's actually a case as well. And I think we do need some imaging. That's not a problem. But I think it's just whether I'm not clear when we should be asking just for a CT versus a CTPA.
I think a CTPA would be beneficial if you're going to do a CT anyway.
Yeah, that's what I was thinking as well. Yeah. Actually, yeah. But okay.
Unless
I thought, if they're going to the scanner, I would have thought you should take advantage of the fact that they're going to the CT to actually do CTPA.
Now, can I just ask? So, will you get the same information on the CTPA about the rest of the lungs? Because you've got contrast away now, so you can see it, can you?
You do essentially, unless anyone wants to contradict me. I think. As far as I'm aware anyway, in the ways that the CTPAs are done now, the amount of information you get on from the lungs is very similar to what you would get from just a high resolution chest CT on its own.
Right.
Great. Okay. Got patients who I'm trying to make that decision on right now. Thanks very much.
Thank you very much. Thank you, Richard. I'll send you a link to the recording of that later on.
I just wanted to echo what Meg said, actually. I think it's a very good message, though, to give patients who are going home, is that the large majority are getting very, very much better and are recovering, and with very few long-term lung or cardiac effects. It's obviously something that we feared at the start, but the incidence of long-term COVID lung, whatever that is, it doesn't seem to be there at all. So it's something that's very reassuring. And this long COVID syndrome doesn't at all seem to be related to the severity of the initial illness.
Sure. Very interesting, and thank you for that. Okay, I think it's 2 o'clock, so we ought to wrap up. I'll pause the recording and say thank you very much, Richard. See you all next week. There's a case already prepared, apparently, so